Before you interpret any chest x-ray, ask this: can I even trust the image? In this video, how to check patient positioning on a chest x-ray, I'll show you a fast and easy way to determine that the chest x-ray positioning so that your chest x-ray decisions are based on good x-ray image quality. Hey guys, I'm Dr. Busti and welcome to another topic review at This Is Why, a show that helps healthcare professionals transform their medical knowledge from not just knowing the what, but understanding the why, so that what we do every day in clinical practice begins to make sense and you don't have to memorize it. All right, let's go ahead and get started. Before you ever ask what pathology is here, you should be asking, is this chest x-ray positioned well enough to trust and to interpret? There are three considerations in answering that question. First is considering projection, APPA, view, and posture. Second is rotation of the patient. Third is centering and overall coverage. So let's address the first, projection and posture. That starts with knowing what type of chest x-ray image it is and, even more importantly, how it was obtained. Now, for those of you joining us via the podcast channels, I will do my best to walk you through this as close as I can, but you may have to move over to the video if you want to see some of these images if you're not as familiar with them, okay? Okay, so when we get a portable chest x-ray, we need to consider the projection that we're obtaining, right? So these are examples of very common portable x-ray machines where we have the x-ray tube on an arm, and you can position that arm angled closer away from the patient. You can move this thing around the room. They usually hold the detector plate that you place behind the patient or the object that you're trying to image. This becomes relevant when we start thinking about a portable chest x-ray and the type of image. So this is about projection. So is it an posterior anterior view or is it an anterior posterior view? Well, obviously if the patient is lying in their bed, so they're in the emergency department, they're in a hospital, internal medicine floor or unit, or they're in the ICU, sometimes possibly on a ventilator, right? They're going to potentially be supine or semi-erect. And they got other things in their bed, right? And their posture, which becomes very important to understanding the positioning of the patient. If you look at this patient here, you could see that they're not standing upright and have their arms laying out to their side, equally like this patient who is able to ambulate into the radiology department and participate potentially more than a normal, otherwise healthy patient in a hospital who's sick. Right? That includes following basic commands, having the strength to move their arms, even to stand up. Okay? All of these things influence the type of position that the patient can be in and the image that we're acquiring that influences our then overall interpretation, assuming that's even a good image to begin with. So a patient in bed, like over here on this side, the detector plate here gets inserted behind the patient, and the x-ray tube that shoots out the x-ray beams towards the patient is going to go from the anterior portion to the posterior where the detector plate is located. So that's an anterior posterior view when done in a hospital bed in most cases. Now, obviously this view over here is also anterior posterior, but typically if we're taking the patient to the radiology department and they can participate, we're going to have that patient turn around and do a posterior anterior view. And that's what I wanted to show you. You can see the differences in position from an AP to a PA. Also look at the patient's arms and their posture, okay? And also alignment in the image can also be easier. You can even see on the lateral view the elevation of the arms, which is why we don't typically do those, obviously, in a hospital bed. That's very difficult to accomplish appropriately. But we want the humerus and the arms out of the way because of the interference of the imaging on a lateral view. But the other thing that's important to recognize here is in a PA view, the patient can wrap their arms around and sometimes even grab the handles, which pull the scapula out of the way. Okay, so this has all been about projection, AP versus PA, and knowing how it was acquired and considering how is that patient positioned in the bed. So when we think about the purpose of this topic, we need to put it in the context of other things that we learn. I teach the RIPE mnemonic, R-I-P-E. This is used, not just by me, but other people as well, to help us to ascertain and discern if the image that we're looking at is of appropriate quality. And the very first thing up there is there any rotation of the patient? And there are some criteria that we use to help us discern that. And I'm going to walk you through those here in just a second. But I wanted you to see that in the context of why we teach these mnemonics and how they fit into the bigger picture of other mnemonics. For example, the utilization of the A through I mnemonic. Again, it's one that I've chosen to use. I systematically read my x-rays in this format. But part of the first thing that we have to discern is, do we have an adequate image to interpret? Is the quality appropriate? And the rotation and positioning of the patient based on the type of projection that we are acquiring, okay, you see projection here, all of those things weigh into why it's necessary as you're assessing these x-rays. All right, so why does this matter? I'm focused on it a lot here about this projection. Well, because it relates to the position and the posture of the patient. And so when you are looking at an AP film, and depending on what your patient's history is or the reason why they're there seeing you or you're managing them, one of the things that might be there that you're concerned about is heart failure or cardiomegaly. Well, AP films have the ability to magnify the cardiac silhouette because the heart sits closer to the x-ray tube versus the detector plate that is behind them in an AP view, which is why, again, people would switch and go to a posterior-anterior view to get the heart closer to the plate. So what about this posture? Thinking about the patient being erect versus supine, why does that matter as it relates to positioning? So again, coming back to the patient who's laying in the bed, who's getting a portable AP chest radiograph versus someone in the department who can stand up and be more erect and aligned perfectly for the image acquisition. This patient over here in bed in a semi-erect or even potentially supine view can hide things like pleural effusions, a pneumothorax, because fluid and air will redistribute differently than when you're upright, okay? That's why some of this matters. There is always going to be some degree of movement in a patient, especially one laying in a bed, okay? So there is some flexibility, 5 degrees, you know, some level of forgiveness there, okay? But what do you want to look at on the x-ray that's very practical for assessing if the patient is rotated too much? Well, one of the things that you want to look at are the medial aspect of the clavicles, or the clavicular heads. So here's your clavicle here on the left side, and here's your right-sided clavicle. And you're looking at the clavicle and the clavicular heads in the context of the spinous processes that are also exposed. You can see those here running down the cervical and then eventually into the thoracic spine. What you want to see is that the clavicular heads, if you follow them around, are roughly symmetrical and equal distant in that area, okay? So the spinous processes should not only be midline as seen in this image, but should also be equal distant from the clavicular heads. The other thing that's important to recognize is also this patient's scapula seems to be symmetrical and appears to be roughly the same distance from the thoracic spine. Both of those things become very important in assessing if there's a certain degree of rotation. So why does this matter? One, rotation can make the lung look more lucent, and the other sometimes more opaque. Two, the rotation can distort the cardiac and mediastinal silhouette, mimicking things like cardiomegaly, mediastinal shift, and even hilar enlargement. Okay, so one of the things that I think is very important and valuable is that you see an example of what that looks like. So you compare it, the normal to the abnormal. And you can see here, we got our normal on the left, but look at that cardiac silhouette on the right side. I mean, you're talking about an outline that is massive. Something is not right. But look, here's the problem. Here's your spinous processes right here. But here's your trachea. That patient's not aligned midline. The other thing is the left clavicular head is here. The other one is over here. So you can see that the distance there is off. They're not equally or symmetrical. And so as the body moves, so does the orientation of the actual heart and the great vessels that come off and start to distribute throughout the body. And that's why. So this is a great example of that. Now, there's some other things going on with this patient, but the point of the matter is the patient is rotated and it's distorting your mediastinal width as well as the cardiac silhouette. So let's now consider the third factor, which is centering of the patient and the overall coverage of the image that you're seeing. We want full coverage. So the lung apices, which are up here, typically above the clavicle, they should be visible and above those clavicles. Also, your costophrenic angles should be visible and included. Lateral borders of the ribs and soft tissue, which you can see here, are also included, and it comes so that you get adequate coverage of all the major lung fields and other parts that again are covered in the A through I mnemonic, okay, that I teach. Now, the scapula should be rotated off the fields, especially if that is a PA view. Remember, because they're wrapping their shoulders around, which are going to pull the scapula around the rib cage and out of the way. So why does some of this stuff matter? Well, because clipped views of the apices, you're going to miss potentially a small pneumothorax. What about clipped or missing portions of the costophrenic angles? Well, you're going to miss potential effusions, pulmonary edema, basal pathology, okay, that may also represent some opacities. Basically, if you can't see both the apices and both costophrenic angles, you can't fully clear the lungs. And that image is not sufficient. It may be the best image you can get at the moment, but you probably need to repeat it. All right, so those represent the three considerations in determining the right positioning of a patient that got a chest x-ray. Number one, that projection and posture. Number two, rotation. And number three, centering and also coverage. Take-home points as to why this is clinically relevant. Remember, number one, calling cardiomegaly or mediastinal shift or enlargement on a rotated anterior or posterior image can create false perceptions, right? The heart looks bigger, the mediastinum looks off-center. Always, always check the projection, consider that, and the rotation before judging the heart size. Second, diagnosing pneumonia on a poorly inspired film. Underinflated lungs, look at the basis, look a little bit hazy and sometimes crowded. can mimic things. If the diaphragm is high and you have fewer than 5 ribs anteriorly, think, man, you got poor inspiration before you call that pneumonia. 3, ignoring coverage and assuming normal, right? Declaring a film as normal without the apices being fully there or the costophrenic angles being there, being cut off, puts you at greater risk of missing something. So my suggestion to look at any x-ray or any radiographic image for that matter is this. If you can't see it, you can't clear it. All right, guys, I hope you found this to be helpful. Please subscribe to us at our channel at YouTube. And please like the video. It helps us to, get the support we need to keep this stuff going for you guys and to keep it free. If you want access to some of the downloads, images, tables, things like that, we offer those free at thisiswhy.health. You get other things like access to collections playlists, discounts on prep test kind of material. You can ask questions and those kind of things. If you want to see this topic put together in a more comprehensive, review on how to read a chest x-ray, I did a topic review on how to read a chest x-ray like a pro. And that's where I cover both the right mnemonic and the A through I mnemonic in more detail and pull it all together so that you can do that well. All right, guys, I hope you found it helpful. We'll see you next time. Take care. Bye-bye.